Medical Dialogues. I am Dr. Nandita Mohan, and today I will be sharing an interesting report that is titled India Works, that is integrating diabetes prevention in workplaces. Now, this research was conducted by the Public Health Foundation of India in association with Dr. Mohan's Diabetes Specialities Center and Madras Diabetes Research Foundation, Chennai, Sree Chitra Tirunal Institute of Medical Sciences and Technology in Trivandrum, Emory University, and Harvard University from the USA. Now, conducted over a period of 6 long years, that is from 2016 to 2022, which makes it one of the longest surveyed reports in the corporate world, the India Works report highlights the need for strategic health-based interventions at company worksites to ensure employees' overall well-being through a structured lifestyle modification program, improving the dietary quality, increasing physical activity levels, and as well as promoting healthy food choices in worksite canteens. So the team released their results, and this is what they had to share.
We are going to talk about the value of partnering together with worksite across India, and how through that partnership we can improve employee health. And that's what all about India Works. Let me start with some non-facts of diabetes in the working population. We know that diabetes is a big issue. We have been already talked about that. But people with diagnosed diabetes incur 2.3 times the medical expenses of a person without diabetes. But the good news is that diabetes is preventable. And we know that it incurs a huge economic loss due to the treatment-related aspects, complication-related aspects, and on an average, it reduces the life expectancy by 5.4 years. So we developed a program to prevent the onset of diabetes. That's what India Works through a mixed method implementation study. This is not a randomized controlled trial. We thought that we know the evidence to implement what is required to prevent the onset of diabetes in the worksite setting. The goal was to evaluate worksite-based lifestyle interventions across multiple worksites, different cultures, different contexts, different languages across India, and then to inform the scale-up of diabetes prevention strategies across multiple worksites, not only the worksites who have been participated part of this program, but other worksites across India. So as part of this program, we did an initial screening across 11 worksite settings. The screening involved 6,265 employees from 11 worksites. They volunteered to be part of the screening program. And what we found in that screening, 9 of 10 had overweight or obesity, 4 in 10 had hypertension, and only 3 of 10 individuals were aware about their condition, were aware about their hypertension status. They could only get to know that they had hypertension because of our screening program, even in worksites, well-educated, settings. And then 5 of 10 were at high risk of development of diabetes, and we invited them in our program. We also found that these risk factors, these risk conditions, cardiometabolic risk conditions, they don't exist in isolation. They cluster together. If you have diabetes, you have relatively high chance of hypertension, you have relatively high chance of having hyperlipidemia, and also cardiovascular diseases, and vice versa. And these conditions in isolation, it occur only in a very small proportion of the population. Otherwise, it co-occur with other conditions. What does it mean? It increases your chance for developing a future cardiovascular diseases multiple folds as compared to individuals without these risk conditions. And we also looked at what are the main driver of this clustering of risk factors or clustering of risk conditions like hypertension, diabetes, hyperlipidemia, and multiple these conditions together. The main driver was obesity, and we looked at both general obesity based on the BMI measures and central obesity based on waist circumference measures. On an average, people who are obese are likely to have 2 or 3 times more of multimorbidity as compared to those people without obesity, general obesity or central obesity. So then we thought of intervening there, developing the program, which is we call it as India Works program in the workplaces or worksite settings across India. The program includes both individual training, group sessions by a peer leader. These peer leaders are selected from the industry. We train them in providing lifestyle education, structured lifestyle education to all the potential participants. Additionally, we influence the management to make substantial changes in the work sites so that the people can adopt these interventions. As all of you know that we need an enabling environment to make our lifestyle changes or behavioral changes. That enabling environment was provided by the worksite management so that the employees could enjoy the benefits of the protective environment. And we selected high-risk group people, 2,108 group, 108 employees from 11 worksites into our India Works program. And in terms of our baseline characteristics, they were middle age. The average mean age was around 45 years. Large majority of them were males. As you know that in the worksite settings, there is a male predominance. Tobacco use was 6.2%. People who are non-hypertension was 45.7% in this particular group. Non-diabetes was 31.3%. And then we implemented the India Works interventions. This includes multi-pronged strategy of lifestyle education classes, 13 classes initially, 12 classes initially, plus 6 additional classes with 3 monthly maintenance sessions. And in addition to that, the worksite extended this one by having separate schemes or separate programs in their worksite based on their cultural settings. Some worksites introduced Zumba dance, some worksites introduced yoga programs, some worksites extended it to their family members, involved children and family members of their employees as well. So we provide structured lifestyle education through regular classes as part of the India Works program, and we looked at the attendance in the intervention classes. It provides us an indicator of acceptability of this program in the worksite settings. On an average, 64% of the enrolled participants were graduated. That means essentially at least 10 classes they attended or actively participated in the monthly sessions. So 64% of the 2,100 odd individuals completed or graduated in our program. And then some feedbacks through our qualitative interviews. We realized that we modified the interventions, adapted the existing knowledge, we culturally adapted the interventions. So the worksite manager was saying that when you tell the participants you are pre-diabetic, you are hypertensive, you are diabetic, they feel offended. The employees feel offended. So they feel bad. So what they did, they communicated that you are a high-risk individual and there is goal for improvement. The moment they came to know that there is a goal for improvement, they started changing their lifestyle practices. It generated sufficient demand in the worksite settings. Our peer educator, the key actor who played an active role in facilitating the intervention, she said, people had doubts as they believed they were doing all in their houses. We all say that, isn't it? We are all doing lifestyle modification. We are all interested in lifestyle modification. We are all doing it. Many people believe that we are doing it there in our houses. And then they were unsure about the program, whether it would be of any use. People initially find it difficult to get their head around it. But once the peer educator explained the purpose of it, the scheme of things, the intervention schedule, people started getting interested in it. And once they started attending the classes, they started attending it regularly, and they also proactively approaching the peer leader about the next classes. They wanted to participate in the next session. So it was that kind of demand generating in the worksites. Then it also received management support, which was very crucial for spreading the message and also getting the employees enrolled into the program. And our peer educator said, if the controlling officer is not supporting, we won't be able to put the work on hold for a while and conduct classes. Without the permission from the controlling officer, nothing can be done. But Sir was very supportive, and because of that, conducting classes and putting the work on hold was not a challenge. So we need the support from the industry management. The HR needs to provide the support. The management needs to provide the support. Otherwise, the employees will not be able to participate in a program like this. But in India Works, we receive the management support across multiple sites. It also ensured peer support. The peer support in terms of supporting each other. Our implementation staff member at the worksites, she was saying that the participants themselves took up an active role. They challenge others by saying, you could also do it. If I could do it, you could do it. So we introduced something called a pedometer to assess the physical activity. So they were all checking their number of steps that they take every day. If somebody is taking 8,000 steps, he or she will tell the other person, I took 8,000 steps today. That motivates the other person to improve their steps count in the next attempt. So the other person would come and say that I increased it to 8,500, 9,000. So that introduced the competition, that improved the physical activity level across the employees who participated in this program. And quantitatively, we need to also think about whether this program introduced some changes quantitatively. So we are releasing the results for the first time in the India Works program. On an average, at the population level, we look at the BMI, the body mass index, which is the ratio of your weight upon your height in meters square. So on an average, the BMI reduced by 0.31. At the population level, it's a big achievement. If you look at the weight reduction, on an average, at the end of 2 years, the program reduced the body weight of all the participants 1.1 kilogram. At the population level, it's again a big achievement. And in terms of the waist circumference, all of you know that it is very difficult to decrease your waist circumference. The waist girth is something very difficult to decrease. But on an average, at the end of our 2-year follow-up, on an average, the employees reduced their waist girth or waist circumference by 1 centimeter. At the 1 year time point, it was 1.8 centimeter. But you all know that COVID hit in between. The program was running through the COVID period as well. So there was some changes after the first year period. And most importantly, it's not only weight or BMI. We were able to reduce the blood pressure. On an average, the blood pressure at the end of the 2-year follow-up, it reduced by 3 mm of Hg, systolic blood pressure. And the implication of this 3 mm of Hg, it could potentially avoid at least 15 to 20% of hypertension from the population. And similarly, we found smaller reduction in diastolic blood pressure as well. If you look at the main indicator of change in the glycemic status, which is glycated hemoglobin or HbA1c, at the end of the first year follow-up, on an average, the glycated hemoglobin reduced by 0.25%. The effect waned off by the end of 2-year period, but I will show you some additional results related to HbA1c. So this was the distribution of HbA1c at the baseline. So we selected individuals who were relatively at high risk of development of diabetes. So all of them had an HbA1c of more than 5.7% at the baseline, all the participants. So at 1 year follow-up, now you could see that the proportion of people below the 5.7 mark is shifting towards the left of the distribution curve. That means there were a large number of people brought down their HbA1c level below the 5.7 mark. At the end of 2 years, they were further spread towards the left of the distribution curve. And at the end of the 2 year, we could bring back to the optimal glycemic level, optimal HbA1c level in 549 of the 2,108 participants. So they were able to get it back to the normal. It's not only reducing on an average, reducing the glycemic level or HbA1c level, at least 25% of them were able to get to the healthy level, the optimal level as well. And who are these people who got their HbA1c regressed back to the normal level or optimal healthy level. So the most important thing in this slide is that the last component, participants who are graduated. On an average, the participants who are graduated, they achieved better regression to normal HbA1c level. 84% of the participants regressed to the normal levels where participants who are graduated from our program, as compared to other participants, those who did not achieve the HbA1c levels. It was only 52% those who completed our intervention session. Essentially saying that if you participate in the intervention session, if you actively engage in the intervention session, the number of classes that you participate increases, there is higher probability of you to get your glycemic levels back to healthy individuals level. So the key results in summary, 2,108 employees were eligible to participate. They were middle-aged, 46 years. The intervention was culturally acceptable. 64% of the participants graduated in our program. At the population level, there was an average 3 millimeter HT reduction in systolic blood pressure, which can translate to a 15% reduction in hypertension. Average 1 kilogram reduction in weight. Population level reduction of 1.1 to 1.8 centimeter waist circumference, and HbA1c regressed to less than 5.7% in approximately 25% of the participants. And those who completed the India Works interventions more likely to regress to the optimal HbA1c level. The regression to the optimal HbA1c level was related to the number of classes they attended. Thank you very much.
So, sir, according to you, how can the project be sustainable in the long run? As in, what measures need to be reinforced at the workplace or the work front to actually sustain this concept?
I think there are a few things that we need to do. The first thing that what Dr. Jimon showed is that there is a saying in English, it takes a village to bring up a child. Similarly, to get this kind of a program, you require the cooperation of everybody. That is the management, the trade unions, the HR, the medical staff, as well as the worksite employees. If there is no buy-in from the worksite employees, you can't do anything, whatever you might do. The second thing that is important is to make things easier for people to change their lifestyle. Number one, let's say that we tell people to take the stairs. In many work sites, when we worked earlier, we found that they're not lit up, they're dirty, so nobody wants to use it. So you put up posters, you light it. It's hard. It's going to cost it won't cost much. So if you do that, people will be attracted to do that. Take the staircase at least for 3 floors. Similarly, in the canteen, you should give healthy food choices along with the ready choices. Third is, I think if we have to have what is called as a stakeholder consultation, you have to consult with the worksite employees if you have to change something. If you bring in a top-down approach, they are going to resist. So they have to have an ownership of what they develop, and then they will accept. I think these are 3 or 4 important concepts that we have to have. The last one is a business case. We have to make a business case. For example, investing in this prevention program, how much does it cost? And because of this, you saw how many people had brought down their HbA1c levels below 7. So it was nearly 40%. Suppose, let us say, at least 20% of them received treatment. What would be the cost? So we need to show, and actually that's an analysis we'll do later on. We need to show that how much is the saving for the companies. And not only that, absenteeism reduces. And there is something called presenteeism. People come to work, but they don't work because they're not well. So that also reduces. The company output increases. So I think we need to show a business model for them, and we need to talk about the simple things.
Thank you so much for your valuable insights. That's all for today. Stay tuned to Medical Dialogues for latest updates.
Never miss a medical update from Medical Dialogues. Like, subscribe, and press the bell icon.